Good morning, my name's Alan Bagnall. I'm an interventional cardiologist at the Freeman Hospital in Newcastle upon Tyne. Today we're going to do a case of primary PCI. So the history that we have is that we have a 55-year-old male who weighs 84 kilos who had onset of chest discomfort at 11 a.m. He made a call to the emergency services at around 12 o'clock and the ambulance team arrived there at 12:15. They performed an ECG at the site, which we will show now. And this shows inferior ST segment elevation in leads 2, 3 and AVF, along with some heart block. They administered some drugs at the time. They gave him some aspirin, oxygen and morphine for pain relief. The ECG was sent by telemetry through to the coronary care unit and he was accepted for primary PCI and arrived to the cath lab at just past 1 o'clock. Now, on arrival to the hospital, we have some questions that we need to ask the patient, in particular relating to their ability to comply with dual antiplatelet therapy and to what other comorbidities that they might have. In this case, there were no concerns with either of those. So the type of additional antiplatelet treatment that he might require would be either clopidogrel or one of the newer agents such as prasugrel or ticagrelor. And most hospitals will have a local policy as to which one of those that they prefer, but each are given with a loading dose, so that would be 600 milligrams for clopidogrel, 180 milligrams for ticagrelor, or 60 milligrams for prasugrel. And we have to remember there are some limitations to the use of prasugrel in patients who've had previous stroke or if they have a low body mass index. The second question, once the patient arrives in the cath lab, is about the optimal pharmacotherapy. Again, there's been lots of debate about this and there are lots of ongoing trials which are examining this question. The options lie present between use of bivalirudin as a monotherapy agent or using a combination of heparin with a glycoprotein 2B3A inhibitor such as abciximab or one of the small molecule agents such as tirofiban or eptifibatide. Each have class 1 indications in the European and American guidelines, and as I say, those trials ongoing assessing superiority for both prevention of ischemic events and for bleeding events between those different agents. Well, as you can see, we've already gained access here. I prefer using the radial route to reduce the risks of bleeding following angioplasty, but many centres also use the femoral route for primary PCI procedures. There's also debate about whether it's best to shoot the non-culprit artery first and get an idea of the anatomy in the non-culprit artery, or whether to proceed directly to the culprit lesion to reduce the overall time of the procedure. In our case, I won't show you the pictures of the left, but the pictures have shown no significant narrowings of the left coronary system, and also there's no collateralization of the distal right coronary from the left. So we've taken a Judkins Wright 4 guide catheter, which has entered the ostium of the right coronary artery, and we're just about to take our first angiogram of the RCA. And as you can see, the right coronary artery is occluded in the mid-vessel, just about at the point where the RV marginal branch comes off. When I take my angiograms, I tend to leave my foot on the pedal for a longer period than normal, because sometimes you get a bit of flow of contrast through the lesion and you can get some distal opacification, which can help guide guide the anatomy for where you want to deliver your wire to. I'll take a picture over in the RAO view next. Okay. Again, a long run, but we're not seeing any extra flow through. So I'm going to come back and I'm going to start working the LAO view. So clearly the first things that we need to do here after our pharmacotherapy has begun is decide whether we need any additional pharmacotherapy. In this case, I'd elected to use heparin, and the patient has had 70 units per kilo of intravenous heparin. We've given 300 milligrams of aspirin in the ambulance. I've chosen to give the patient 60 milligrams of prasugrel as they've arrived in the cath lab, and I'm going to give them some glycoprotein inhibitor as well. And again, there are various protocols for how this can be given, whether it's intracoronary or intravenous, but if we could have some intravenous glycoprotein inhibitor now as well, please. And I'm going to be taking an 014 guide wire. Typically I use a spring-coiled guide wire. The risks of using polymer jacketed wires are that they can often find small side branches, which if you're using aspiration you don't want to inadvertently follow. So we should see our guide wire appearing very soon. Here we are. I'm just going to take my talking device onto my guide wire. A lot of this part of the procedure is about feel. Again, we're always trying to be as gentle as possible with the wire, trying not to use any particular force, letting it find a way through the thrombus. And you use your mental roadmap of what a typical right coronary artery distal anatomy should be to determine whether you're going in the right places. But you should always be cautious when you're doing this, because anatomy can vary quite considerably. And what you don't want to be doing is taking the wire into any small branches. So I advance the wire into the right coronary artery. And we're going to be coming down to approximately where the lesion is. So I've got quite a lot of movement on my wire. This is where the obstruction is. And I'm just coming back. If there's any concerns about where the wire is, a little test injection just to make sure you're in the right place. As you can see, our guide catheter there had gone into a small branch vessel. And we just want to make sure that we're not repeating the same mistake again. And we're still in that same vessel. The guide catheter here is a little bit deeply engaged in the ostium, so we're just bringing it back, and I'm going to try and redirect my wire. We may have to come back a little ways. Here we go. So that looks a lot better now. Little injection just to test, but that's much better. Okay. So we're down at the lesion here, and again I've got a little bit of movement on the wire, just kind of feeling our way through. I can see it made a little bit of advancement there. And I'm watching carefully for the direction that the wire is going. Again, there's a chance to bring in to pick up some side branches. That looks like it's going in the direction of the distal right, probably there just at the bifurcation. The patient's a little tachycardic at this point, and it's not unusual for them to become a little bit hypotensive or for us to see some reperfusion arrhythmias around about this time. So keep an eye on the ECG. Once the guide wire is through, we'll often see some flow. So I take a cine at this point and see whether we've got a better understanding of the anatomy. There's a small amount of blush just coming through. I can see my wire. Looks like we've managed to avoid that RV branch, and we've got the wire in the distal RCA. So I'm happy with where the wire is now. I don't think I need to take it any further down. So it's clear from this that despite the glycoprotein inhibitors and the heparin and the antiplatelets that we have on board, we still have a significant thrombus burden. And what I'm going to do is perform aspiration next to see if we can pull out some of that clot from the coronary artery and improve flow, and to minimize our chances of no reflow following stenting. So there are a number of different aspiration catheters that are on the market. All follow the same basic design, which is a hollow tube to which you can attach a syringe which can be kept on negative pressure. So the catheters are flushed through with water first, the syringe attached via a three-way tap and placed on negative. And they're all rapid exchange devices, so that we just pass it up in the wire just like you would for a balloon, and it goes up the catheter on negative, but without currently the tap being open. So if I could just ask you to fix that wire, please. Okay, I have the wire now. Now, we can see our aspiration catheter is arriving at the distal end of our guiding catheter, and just as it merges out into the right coronary artery, I'm going to ask my colleague to turn on the aspiration. So this is opening the tap, so it's now actively withdrawing blood from the artery. We start to see blood fill up the syringe, and that tells us the aspiration is working okay. And we gradually and slowly advance our aspiration catheter towards the lesion, and if possible to go just across the lesion. You don't need to go a lot across it. The crossing ability of these catheters varies a little bit, and it's also going to be dependent on the degree of stenosis at the lesion as well. So you get some clues as to how high a degree of stenosis you're dealing with. After you've crossed the lesion, again, it's slow withdrawal of the catheter, gently rotating it if possible to try and get as much thrombus out as possible. And then you withdraw it back into the catheter, keeping it on negative all the way right until the device itself is completely removed out of your guiding catheter. The reason for doing that is that you can get large clumps of thrombus stuck at the end of the aspiration catheter, and what you don't want to do is to release the negative suction power and to drop that inside the guide catheter and then inadvertently inject it during your next angiogram. What I typically do is to bleed back out of my co-pilot, or to aspirate from the side arm to completely ensure that I've got rid of any bubbles or any clot from the catheter. It's not uncommon as you take the aspiration catheter out for a whole load of air to get sucked into the system, so make sure that's all removed. So we're going to take another angiogram now and see whether that has improved flow. Okay, and it's improved flow quite considerably. But what we can see off our angiogram here is that we have a lot of spasm in the proximal part of the right coronary artery. Interestingly, we can also see a little bit of filling of the left system as well. So I'm going to give a little bit of nitroglycerin intracoronary, 200 micrograms. Next one down. Here. To try and relieve that spasm. Often during primary PCI cases, I will, if the blood pressure is reasonable, here we're a little low at, our blood pressure at the moment is 95/51. But if the blood pressure is reasonable, I try and give repeated boluses of intracoronary nitrate. The reason for that is that I want the artery to be as dilated as possible before I make my decisions about stent sizing. Often when the patients arrive in the cath lab, there's a lot of adrenergic activation, the coronaries can be in spasm, and you can end up undersizing your stent, which could cause problems in the longer term. So I'll give another bolus now of intracoronary nitrate again, please. Our blood pressure is a lot more settled now. Heart rate is much better, 110. And we'll take another angiogram. We can then decide about vessel sizing and stent sizing. Hopefully our spasm will have gone by this point as well. So the spasm's improved, and the vessel itself is a pretty decent size. It's probably around about a 4.0 vessel. We've got a short lesion just beyond the first RV marginal branch, and it extends to just proximal to the second RV marginal branch. I'm going to take my guide wire on a little bit further. Obviously, I can do that a lot more comfortably now that I know the anatomy distally. So the next question is really about whether you undertake any predilatation of the lesion. with a balloon or whether you go for direct stenting. There's pros and cons of each. If you predilate the lesion, you'll have a better idea as to whether there's any, whether the lesion is expandable. But on the other hand, you will cause further embolization when you do that. So there are trade-offs with each manipulation you make within the coronary artery. I think in this case, we've not seen any calcification of the lesion. It's a young patient, and I'm pretty happy with going for direct stenting. So, choice between bare metal stents and drug-eluting stents. We've had the discussion with the patient about their ability to comply long-term with dual antiplatelet therapy, and about whether they might have any upcoming medical interventions or surgeries that might require them to interrupt dual antiplatelet therapy. Both of those are important to establish beforehand if you're going to use drug-eluting stents. The potential advantage of using drug-eluting stents is simply that you're less likely to have target vessel revascularization needs in the future. There doesn't appear on the big trials to be any particular penalty to pay in terms of late stent thrombosis with the newer generation of drug-eluting stents. So I've selected a 4x12 drug-eluting stent, and we'll just put that in now. Thank you. The nice thing about primary PCI is that really once you've done the aspiration and the vessel is open, the patient feels immediately better. And you take someone who's gone from being extremely sick, you know, even to the point of being in cardiogenic shock, and within a couple of minutes you've turned things around completely, and they're chatting to you normally and feeling lots better. Sorry, I'm getting a bit caught up here. You could just fix that wire for me, please. Okay. Take my wire in a little bit further again, just to give myself some reasonable amount of support. And stent's tracking nicely. Take a little test here to see where we are. So I'm just going to come in another millimetre or so. Let's take a cine here and just document our intended stent deployment site. Okay, that looks fine. I'll just screen this up. Okay. Okay, so we're about to deploy our stent here. And I'm going to take this up to nominal pressure, 10, 12 atmospheres. Again, higher pressure inflations can lead to problems with further distal embolization. I've actually gone to 14 there. That looks reasonably well expanded now. And I typically leave the stent, the balloon up for about 30 seconds. I'll do a little bit shorter here just for the sake of time, and we'll come down again. And we'll take our balloon out, our stent out, sorry. Give a little test here. It's a good practice generally to make sure that before you completely take a balloon out of the catheter, you take a small test shot just to ensure that if you've had the worst case scenario of having a perforation, that you've got a balloon there in place that you can put straight in and just tamponade the vessel. A little test here. So that's great. So it looks like the stent is well expanded. I'm just going to take another shot of that, just a cine of that. The stent looks well expanded. It looks pretty well sized. Again, if I've I try and make sure that I size my stent appropriately first time, because if you're having to do post-dilatation of the balloon, you're likely to get a bit more embolus, and that increases your risk of no reflow. We'll come into a different view now. Let's come into the REO. Okay, looks good from that point. Lots of collaterals over to the left. Always worthwhile taking a wire out shot as well. I'll just come back into our LAO. Sometimes the guide wire can be holding some dissection flaps open, so you're not aware that you've had a vessel dissection until you've actually got the wire out. So, useful thing to do to take a wire out shot just to make sure that everything looks fine. And there we go. So that's primary PCI. Generally they're very rewarding procedures to do. Immediate impact on the patient, they feel great straight away, and it's very easy to know whether things have gone well. The types of problems that you might run into later, might run into after stenting, we haven't encountered here, are things like no reflow, and that's often due to distal embolization of a thrombus or plaque components, made worse if the patient has any degree of microvascular obstruction caused by edema related to the infarct itself. Typically, that treatment of that is going to be pharmacological, and that could be using things like adenosine, sodium nitroprusside, or verapamil. And one of the tricks you can do in those situations is use your aspiration catheter as a way of delivering those drugs directly into the coronary circulation, down into the distal vessels in particular. That can reduce your chances of having to deal with the hypotension that some of those drugs can cause if they go more systemically.